Good afternoon. Again, we're just going to try to keep in time. So this is for valve and valve. Our case today is an 85-year-old male who had a previous CABG with a Lima TLD and a vein graft RCA. He had an aortic valve replacement with a Perimount 19 millimeter valve done in 2009. He had a history of COPD, prior TIA, recurrent admission with congestive heart failure. The echocardiogram showed a mean gradient of 50, max gradient of 75. He does have multiple admission with slight elevation of his BNB level. His body surface area is 1.8 square meter, weight is 170 pound, his height is 62 inch. The valve mode failure is stenosis. His echo showed a peak velocity of 4.6 and peak gradient 84, mean is 50. Normal left ventricular systolic function. He does have LVH, and there is no other major associated valve abnormality. His cath showed patent graft. There's a nice antegrade flow in the coronaries and in the grafts. So I'm going to stop here and ask the question, what are the important factors that are helpful for us as an operator to plan a TAVI valve and valve in the aortic position? So I'm going to, for the time, I'm going to go, the valve is a bioprosthetic valve. This is from the valve and valve arm. It's a Perimount 19. The stent inner diameter, true inner diameter is 17. If you go, the axis is reasonable. There is no major contraindication to do a TAVI procedure in terms of the axis. I'm going to go over the CT scan. I'm going to stop here for a second, allow Mohammed to discuss a couple of things about the valve and valve before I finish the screening CT scan.
So thank you, Faisal. So I think this is tougher and tougher. And because of the time, we need to discuss so many things, but because of the time constraint, I think we'll concentrate on two things: coronary issue, and I will show you, if you allow me on the screen, how to calculate, what is my calculation for the coronary risk.
Perimount 19. Inside. Yeah. So by definition, 19 is a smaller valve, 21 is a smaller valve.
Thank you, Faisal. So the question is, I will show you how do I do assessment of the coronary risk when we talk about TAVR and SAVR. And this is very important. I need to draw some of the aortic root and the coronary. I know in this case, there is already patent graft, but does patent graft confirm 100% protection? The answer is no. So you have really to pay your attention to the usual coronary protection or coronary assessment. So if this is the left, this is the STJ, and this is the height of sinus of Valsalva height. This is very important. And according to the data, if you, Faisal, you can, okay, I will just try to remember the data. The RCA stage A is higher.
9.5 for the left main. So RCA is 13.4.
So this is the shape we were given in the CT scan. So the height stage is 14.6 here, and the left, and here 17.7. So the first thing, if you want to put, there is already a surgical valve here. And to estimate the coronary risk, the first calculation you should do is the sinus of Valsalva height compared to the frame, surgical frame. Here it's Perimount, the length is 14. So the length here is 14, and here on the left 14.6. So the distance here to the STG is below 2. So there is a risk on the left. When we talk about the left main obstruction, there is a risk. The risk is high. If we talk about the right coronary, the difference is 3.7 between the sinus of Valsalva height and the frame, surgical frame height. So this is safe. So for me, the right coronary passes the test, but the left main is at risk. So what is next is to measure this area. Before measuring this area, this is a VTC, and this is VT STG. But because to ensure that if this area is enough, you have to make sure that the blood comes from above. I know it's not relevant here because of the patent graft, but it's relevant in the left main, even here. You might destabilize the patient, even if the lima is patent. You might occlude proximal LID, left main, you might occlude the SIR. So the way to do it here, because it's below 2, you have to measure VT STG. And then how to do it, you don't take the cut values on the report because you need the 3D. Look at my hand, you don't need this line, you need the whole 3D. What will be the behavior when you inflate the valve? So the minimum sinus of valves alpha 21 and 23, 25. If you assume that the left, but it should be given to me the sinus of valves alpha width on the left, 21.6, and the biggest is 23. So if you calculate this, it will be at least SVT, STG is more than 2. So the next step, so on the left, although the height was risky, but the VT STG is safe, then the next is VTC is 3.5. So for this case, the right is safe, the left is a borderline. Why I'm saying borderline? Because remember, there is an old disease here, which we didn't calculate. We don't know. There is no way in CT to predict. Not only that, Faisal might decide to post-dilate, fracture the valve. This was not calculated. The inclination to the aortic root, the direction of the valve, surgical valve, like this is different from like this. Like this, even if the VT STG is wide, you might push it by fracture and you might occlude. So for me, in this particular case, intermediate risk on the left, safe on the right. Personally, I will protect the left knee.
Great assessment, Dr. Abdurrahman. There is more information. The VTC is 3.5 in the left main. I will show you the data that Abu Abdurrahman discussed. VTC of RCA is 3.5. Remember, patient has functioning graft with excellent antegrade flow. The RCA is a huge system. The decision is whether or not to protect the left main. So back to the valve. We chose the valve. We went to the valve before I move to the case, this is a very important concept that Dr. Mohammed is explaining. But I just want to point out this concept of VTC of the STJ is literally became available to us in 2022 based on a trial of literally 28 patients who already deemed to be high risk and were going for basilica. And even with that, I will show you the algorithm. But even till this date, I do not know how to put the VTC of the STJ when I have a VTC of the left main more than 6. Do I need even to calculate it? And that is what the algorithm, which is a very nice algorithm, but I want to put a word of caution. This is not necessarily a full algorithm that you need to follow, but this is probably coming in the future where we decide, do we do leaflet alteration? Do we protect, or the case can be safely done without any protection? So the first question, as Dr. Mohammed alluded to, is the leaflet extension above the coronary. Is there a leaflet length above the coronary or not? If no, this is a low-risk case. The second important measurement that we know a lot about from the valve and valve registry is the VTC. The VTC, if you have a VTC more than or equal to 3, that's a low-risk case. If it's between 3 to 6, it's an intermediate. More than 6 is a low-risk case. But with those proportion of patients who you do have a VTC more than 3, then you're going to look at the virtual valve to the STJ. If you have it more than 3, it's a very low-risk case. In addition to that, if you want to do the sinus sequestration calculation, which is the sinus height, the leaflet height minus the STJ, if it is positive, it's a low-risk case, which means your leaflet height is too small or too short to be sequestered above the left main ostium. This calculation can be done, absolutely, but the only thing is this is based on 30 cases that already been deemed high risk, and they did the basilica. And even in those patients who deemed to be high risk, their occlusion rate was 7.1%. So if you look at the screen here, the actual event in patients who were screened and deemed to be high risk for left main occlusion, the actual rate of occlusion was 7.1%. So this is back to the case. So when we go to a valve-in-valve case, in addition to the thorough anatomical evaluation, which is very important, it's very important to define your success. What we know from the valve-in-valve data is leaving the cath lab with a gradient below 20 has been associated with good outcome in 1 year. So this maybe is the pole mark or the marker that we use to define a valve-in-valve success. So crossing the valve, the gradient, the peak gradient was 76. We tried to deploy the valve. I decided not to protect based on the VTC and the fact there is a lima. We try at least in 2 trials to deploy the valve higher than this, and each time when I aim for a higher deployment, the valve tend to pop up and I lose my position. So we accepted this location, although we know within a safe distance, the higher deployment you got in a self-expanding, the better hemodynamics. So now I deploy my valve. This is my gradient. So I'm going to ask Dr. Mohammed, should I leave the cath lab happy or should I do something? The mean gradient is 36. And everybody, please, this is an interactive session. Please grab the mic and ask questions.
Yeah, we will see from the audience. Probably you need to post-dilate.
لا, but think of under expansion of the valve yet, the folding. The folding still is very high for this diameter.
So that's a very important point and an excellent point. The mechanism behind the higher gradient could be still 2. Either we are a small valve or the leaflet is pinned. So despite post dilatation, this is the result we got with post dilatation for a 23 millimeter valve. So I'm telling you, this is the result based on the post dilatation of the valve. Would you leave this or you would think about doing some fracturing of the valve?
So Hussein says fracture. Okay.
I will fracture the valve. First of all, because it's a peri-mount valve, internally mounted leaflet, the chance of coronary obstruction is far less than externally mounted leaflets.
Okay.
Like the trifecta or mitral flow.
Show of hands, please. Who will fracture? Who will ask Faisal to fracture? Okay. Who won't fracture? Who will not fracture? And I want one of those who won't fracture to step and tell us why not to fracture. Abdullah.
And before that person, this you cannot leave the lab with this result. But you have to understand that the VTC is on the assumption that the valve is not fractured.
Yeah.
Now you're going to fracture the valve. That number it means nothing. The risk is much higher. So even though you decided not to protect the left main at that point, now if I will go fracture, but I will wire the left main and be prepared to protect it.
That's an excellent point. And to your point, I did not do that because I thought the risk is still small because even if we fracture, how much of the valve can move? But that's a very important point. And I think this is a dynamic process. If you thought about fracturing with the low-lying left main, you might end up protecting. But I can tell you in this case, we did not do it because I think the false assurance that a lima to an LED is functioning and filling retrograde very nicely in an 85-year-old guy. So the decision to fracture was mainly based on the hemodynamics, and the thought process should always be, is the evolute valve is fully deployed, or am I just dealing with the constraint in the valve? So we decided to fracture, and again, be patient, because that's what happened with us. I will show you the fracture setting, but in general, towards the end, you could see that the full balloon, and I tried to take maximum cine to see the true fracture. Honestly, I could not see it. But what I could tell you is, I will show you next, is the gradient. And this is literally post-balloon, what I claim it's fracture. Or could it be I dilated enough compared to the bigger balloon? But the maximum balloon I used before was 20 for an evolute. This is a 20 Atlas balloon. Now, post-fracturing, the gradient came nicely. This is the echo. A couple of days later, and still the mean gradient is 8. We felt happy, so we left the cath lab. And in general, we'll share 3 slides. One about the setup for a fracture. I think this is clearly available. You could definitely have it in this reference, but having a setup for basically a high pressure balloon, in addition, high pressure syringe in addition to an inflator. There is also a setup for the atmosphere. To be fair, we already passed 20 atmosphere in our valve, and then that when it's fracture, we're supposed to be fracture at 19. Just to keep in mind, those fracture happen in basically external. This is not based on human studies. Now, if we decided to fracture, I think the question becomes available, and I'm going to stop here. When do we fracture? Assuming we did what Abu Talal mentioned, which decide before you want to fracture or not, should we fracture before or after?
Let me confirm a few points, Faisal. Now, what is the maximum balloon you should use to fracture? What is your maximum? Do you go for internal diameter of surgical prosthesis, external diameter? Is there a limit?
So to be fair, there is a very detailed, I just cut the table in relation to the valve that I'm using, but there is a very nice detailed reference here indicating what they have used in the lab to fracture door valve. Each valve, size, balloon, and the atmosphere that it fractured, and even within the same table, it tells you which valve they could not fracture.
The other important point is that if you decide to fracture, is not to exceed the waist of the new valve, which is very important. Otherwise, you might accelerate the structural valve degeneration of the new valve. So I think these are two important, inner, outer diameter, plus the waist of the Medtronic platform. Do you agree on that, Faisal?
Yes, but...
Now, the question is, of Faisal is, when you decide to fracture, do you do it before or after?
That's the question for...
You do
open
it
to
after,
the floor.
because if you do it before, the chance of severe AR, because you are fracturing a bioprosthetic valve, and immediate hemodynamic instability will happen. So many people, they fracture post, not pre.
So probably if you are worried about non-primed left ventricle, that's the structural degeneration is not, part of it is not aortic incompetence, then there is a fear of open AI which will not take it. But if there is a moderate AI and you are sure that you need to fracture, you might do it before. This is one point. Second point is valve and valve in SAVR. So if you have already scared, like in this patient, if you need to put TAVR and SAVR, you might fracture before because you eliminate the risk of AI. But generally, you fracture later on because you might not need to fracture. So I think that's the important point. Go on, Faisal, because of the time for the live case.
Sure. What is important here is, again, before we move to the data on fracture, till recently, probably we have this question multiple times, fracture before or after, but at least now we have some data to guide us. The most important thing, fracture does not come without risk. It's a high mortality procedure. So this is from the STS database and TVT. Basically, nearly 6,000 patients who had a valve and valve. Around 600 of them, they end up with a fracture. The main valve that has been used for here is a balloon expandable valve. And they looked at first of all, they looked at the cohort as a whole. Fracture versus non-fracture, definitely fracture increase your all-cause mortality, increase your hospital mortality, and risk of bleeding. But then they divided that and they started to look at for the people who the operator decided to fracture before versus fracture after. Is there any difference? And clearly, if you fracture after, you had no change in mortality, and you had bigger valve area and you have lower gradient, compare if you fracture before you deploy the valve, which has been associated with higher mortality. So this piece of information now currently available tells us that the old question before versus after, if you could achieve fracture post TAVI, probably this will be carrying less mortality. Now, before I just want to also emphasize, in general, when you are dealing with a valve and valve for the aortic position, defining the success is very important in terms of hemodynamic patient age, because some of those patients, when they are presenting at a younger age, they still can be a surgical candidate. The second part, which is very relevant to our area, is the sizes of valve that we are dealing with. You're going to deal with 19 and 20 millimeter valve versus the 23 and 25 that we used to deal with in North America. So this is very important, and probably either if we think the risk of fracture is too high for that individual patient, then probably surgery might have been a benefit for that patient. Go ahead. Thank you.